So my name is Melissa Naiman, and actually since these slides were submitted, my title is now Senior Director for Medical Affairs for all of acute care. Thank you very much. So I'm a former emergency medical technician, and I have a PhD in public health, so I see my role as helping navigate the often choppy waters between the population-level observations that inform the development of diagnostics and how those get applied to individual patient encounters. I am unabashedly a data-driven person. You don't end up with a PhD in public health policy, maintain a project management professional designation for over 20 years, and work for a company where continuous quality improvement is one of the core values if you don't believe in the value of quantitative measures. But even so, as Sir Austin Bradford Hill reminds us, the pioneer of the randomized controlled trial, it's also important to reflect on the impact of our efforts. And that brings us to Ellie. She's the goddaughter of one of my colleagues, Stephanie Bobrowski. In February of 2022, Ellie was a normal 6-year-old girl living in Orlando, Florida, coloring owls, playing soccer, and leading a normal kid life. Except that she had a sore throat and she was tired. Her parents managed a pediatrician visit a few days later, where she had a rapid strep test that came up negative for strep A. So based on her medical history and her presentation, her doctor had a very low suspicion for systemic illness, and he followed established guidelines and sent Ellie home with her parents with instructions for how to manage a viral infection in a pediatric patient. However, the next evening, Ellie's parents found her in bed unresponsive, and they rushed her to the emergency department. She was quickly admitted to critical care, and her parents were told to say their goodbyes in case she didn't make it through the night. And while Ellie didn't have strep, her inpatient infectious disease workup found that she did have a bacterial infection, and that had progressed to sepsis. Luckily, about 6 weeks later, following a prolonged ICU stay, complex hospital course with a lot of complications, Ellie recovered and remains a vibrant, thriving 10-year-old girl. Now, Ellie's pediatrician did not do anything wrong. He made the best call he could, supported by evidence-based medicine, using the information he had at hand. He's probably seen hundreds or thousands of kids who presented with the same symptoms, similar histories, same lab results, and never had this type of outcome. But even if this is a 1 in a million event and not necessarily statistically significant, it's still relevant. If we lived in a world where it was as simple to screen a patient's host response as it is to identify the presence of common pathogens, Ellie's journey may have been different. And so we're getting close to that world. And I'm excited to share more information with you today about MeMed BV, an emerging yet actionable host response diagnostic that is now available in the UK. So at the end of the day, no matter the disease state, diagnostic uncertainty leads to operational inefficiency, and patients do not receive the right care at the right time. In the case of acute infections, we're looking at a whole slew of challenges brought on by diagnostic uncertainty in the hospital setting. So the most common concern is appropriate use of antibiotics. However, inappropriate antibiotic use is largely driven by a concern for a missed severe infection or sepsis diagnosis. And overall, this uncertainty leads to increased length of stay, both in the ED and inpatient settings, crowding, increased readmissions, and unnecessary transfers. From a provider standpoint, and as Ellie's case illustrates, it can be really hard to spot a patient's prognosis based on their initial presentation. So acute infectious disease is the most common discharge diagnosis from urgent care centers, but it's also the 5th most common reason for an ED referral. In the ED, acute infectious diseases is the 3rd most common reason for a treat and release visit, but it's also the 2nd most common reason for a hospital admission. So diagnosing acute infections is challenging, and frankly, the odds are very good that in most cases, the infection will resolve no matter what you do. And that reality drives most guidelines, both in the US and abroad. However, these guidelines are peppered with phrases like usually or often, which leaves something to be desired in terms of precision. So as a clinician responsible for the care of the patient in front of you and not some nebulous population, do you really want to hang your hat on usually? In practice, it is hard to tell the difference between bacterial and viral infection. Bacterial and viral infections often manifest with the same signs and symptoms, such as cough, fever, and achiness, so it's hard to tell them apart based on a physical exam. Even if blood work is an option, lab values consistent with infection might result from a lot of other causes. So at the end of the day, providers still need to make a call. However, when asked, physicians will often admit that they aren't totally confident in their diagnosis. As part of the SPIRIT study, which tested MeMed BV performance in 1,561 pediatric patients, the investigators asked providers on a scale of 1 to 3, with 3 being very confident, how confident were you in diagnosing this patient? 64% of the time, physicians were uncertain or undecided about whether the signs and symptoms they saw were caused by a bacterial or viral infection. And it was fair that they were uncertain, because when compared to the reference standard established for this trial, MeMed BV significantly outperformed the treating physicians in distinguishing between bacterial and viral infections. So let's explore the clinical value of a lab test that was intentionally designed to differentiate between bacterial and viral etiology. So physicians, especially those based in a hospital setting, have access to plenty of labs. But existing lab tests weren't designed to answer the specific question, is the clinical manifestation I am observing caused by a bacterial or viral pathogen? Established lab tests can answer one of two questions. So one, which pathogen is present? So you can try to get at that from cultures or from genetic sequencing using PCR. And second, is this person, the host, responding to an infection? So for example, you can test in changes in white blood cell populations using CBC-diff, or changes in inflammatory marker levels using procalcitonin through immunoassay. But neither approach is perfect. 60% of pathogen identification attempts fail. The presence of a pathogen may be coincidental to the clinical disease, and lab values consistent with infection might result from other causes. So in 2025, we celebrated the 10-year anniversary of the foundational research behind MeMed BV. From 2009 to 2013, MeMed prospectively recruited 1,002 adult and pediatric patients with suspected infection from emergency departments and hospital wards. A master data set, including demographics, medical history, physical exam, lab results, and imaging results, was compiled and reviewed by an expert panel to create a reference standard for etiology. A total of 765 patients were successfully assigned to either bacterial, viral, or control groups. The model was refined over 3 iterations to identify 3 host proteins that most clearly differentiated between bacterial and viral infections, and then that signature was tested in the validation set of 382 patients that were untouched by the machine learning model to establish the initial performance characteristics of this panel. And what they found is that CRP is elevated in the presence of inflammation, but that elevation is more pronounced during bacterial infections. IP10 elevates in the presence of any infection, but it's more pronounced during viral infections. And TRAIL, or TNF-related apoptosis-inducing ligand, is elevated in response to viral infection, but downregulates in response to bacterial infection. So taken together, these 3 markers participate in different signaling pathways and exhibit complementary dynamics in response to bacterial and viral infections. Unlike current approaches that quantify a single biomarker, the MeMed BV score integrates the dynamic response to these 3 host immune proteins. The score ranges from 0 to 100. The higher the score, the higher the likelihood that the patient is exhibiting a bacterial immune response. Throughout its development, the MeMed BV assay has shown very high diagnostic accuracy. In the pivotal trial that supported its regulatory clearance, it established an overall diagnostic accuracy of 95% and a negative predictive value for bacterial infections of 98.8% in a broad population of adults and children with suspected infection. And they've shown similar performance again and again. Over the last decade, the team at MeMed has established what I would argue is the largest and highest quality body of evidence among commercially available bacterial versus viral assays. In every relevant care setting, in every country, this assay has demonstrated consistently high diagnostic accuracy that has set the stage for meaningful clinical utility. So let's talk about this clinical utility in a bit more detail. One example of clinical utility comes from the second largest health system in Israel. Over the course of a year, around 3,200 MeMed BV tests were ordered and had actionable results. During the study period, providers were surveyed about their intention to prescribe antibiotics and whether MeMed BV had any impact on their clinical decision-making. The investigators found that overall, physicians aligned with the MeMed BV score about 78% of the time, and attested that it aided in their patient management in 86% of all cases. And so this translated into physicians avoiding 63% of potentially unwarranted antibiotic prescriptions, treating 70% of potentially missed bacterial infections, and providing more clarity in cases of true uncertainty. The same group studied the impact of MeMed BV in pediatric patients presenting to urgent care with acute infections. So a total of 1,677 encounters had full survey data. Physicians reported that MeMed BV results changed or supported prescription decisions in 84% of all cases, and overall 78% of prescription decisions aligned with the MeMed BV score. So among physicians who are likely to prescribe antibiotics at the point where they ordered MeMed BV, but the results were viral, 61.7% of patients were not treated with antibiotics. And so these two studies were conducted about 6 months after the introduction of the test and represent about the first full year of use by clinicians in this health system. And the study was conducted by providers within this health system as well. So they felt it was the first year of real use, and though they haven't repeated the study, they feel that the alignment has since increased, and the test remains very popular with their urgent care clinicians. Clinical alignment with MeMed BV scores has been replicated in the interim results of a large randomized control trial. These results were from a planned interim analysis of the Jupiter study, which is designed to demonstrate that following the MeMed BV score leads to more appropriate antibiotic use. So in this study, adult patients are enrolled if they present to the emergency department or urgent care setting with signs of acute infection and are likely to be discharged. So the MeMed BV test is run on all enrolled patients, but the results are only reported to providers who are in the MeMed BV arm. So the MeMed BV arm showed a 50% reduction in antibiotic prescriptions among patients with a viral score and a 24% increase among patients with a bacterial score as compared to the standard of care arm. And in addition, the MeMed BV adherence was associated with a lower 7-day hospitalization rate. A larger real-world study of prescribing behavior was conducted at Maimonides Medical Center and found that a similar magnitude of alignment to the real-world studies conducted in the urgent care centers in Israel. So this was a retrospective study of 681 adults with blood culture and MeMed BV results analyzed over a 2-year period. So in year 1, the test was introduced, but the provider training was limited to email alerts and one presentation at a faculty event. At the end of year 1, Maimonides launched a formalized training. So to your point, keeping people in line with what's expected of them is very important. And so these results coincide with that intervention of a formal MeMed training activity. So in time 2, we see a strong overall alignment, 80%, with the MeMed BV score, and there was a 24% reduction in antibiotic prescriptions in patients with viral MeMed BV scores, and a 5.5% increase in antibiotic prescriptions in patients with a bacterial MeMed BV score. So there was also no difference in 7-day ED return visit rates. So as a health policy wonk, I love seeing reproducible results. So with MeMed, I see reproducible diagnostic accuracy, I see reproducible prescribing behavior in both ED and urgent care settings. But at the end of the day, let's be honest, withholding antibiotics, even if it's the right thing to do, isn't going to impress anybody accountable for a budget in a large healthcare organization. So what might be more interesting is MeMed BV's association with referral behavior, which is also tied to diagnostic uncertainty. Because once a clinician has decided that a patient has an acute infection and that infection is most likely bacterial, the next decision is how severe that bacterial infection is and whether that patient is going to need IV antibiotics. And then the suspected need for IV antibiotics and other likely interventions that go along with that drives referrals from urgent care to the ED and from ED into the hospital. So all three real-world studies that showed strong alignment with MeMed BV scores also showed a substantial reduction in referrals and admissions without an impact on safety. Starting with adults presenting to urgent care, during the study period, a total of 394 patients were referred to the ED for further evaluation. However, providers indicated that the MeMed BV score discouraged ED referrals in 595 cases. So among those discouraged cases, the 7-day hospitalization rate was 3.5%, which was the same as the average 7-day hospitalization rate for the system as a whole. So that represents up to a 40% reduction in unwarranted referrals from urgent care for ED evaluation. In the pediatric cohort for the same institution, a total of 303 pediatric patients were referred to the emergency department from urgent care. Providers reported that the MeMed BV score discouraged a referral in 436 cases, so up to a 41% reduction in ED referrals. The 7-day hospitalization rate among the discouraged cases was no different from cases where MeMed BV had no impact on the referral decision. Interestingly, among the 66 cases where MeMed BV encouraged a referral, about 56% of those patients were hospitalized. So when I talk about safe risk stratification, this is what I mean. The patients who needed advanced care are being appropriately referred, and those who won't truly benefit from advanced care are being managed at the appropriate level. And then finally, the real-world ED study from Maimonides, which analyzed the impact of MeMed BV on 681 patients with blood culture orders, found a 20% reduction in hospitalization rates among patients with a viral MeMed BV score, with no difference in return rates. In reviewing the cost data, they found that implementing MeMed BV was basically cost neutral when they considered operational costs associated with running blood cultures, running MeMed BV tests, and withholding antibiotics. However, when they measured the impact of reducing unnecessary hospitalizations, which is an extremely common occurrence among patients with a blood culture order, they found an estimated $562,000 in cost savings to their institution. And so I'd like to wrap up with a couple of notes about implementation and workflow for the MeMed BV test. So I think the first consideration is that the signature itself, that combination of CRP, IP10, and TRAIL, is broadly cleared for use on patients who have exhibited fever or other symptoms of acute infectious disease for up to 7 days. So one of the critiques from the research community is that this encompasses a huge array of infectious syndromes, which is fair, but I think from a practical perspective, it allows hospitals a lot of flexibility in aligning MeMed BV with a variety of quality improvement goals. Second, MeMed BV is cleared for the widest age range of any commercially available test in this class, from 90 days and older. Third, MeMed BV is uniquely available on low and high volume analyzers, including a standalone version called the Key, which runs about 4 tests an hour, and it is now available in Europe and the UK on the Access 2 and DXI 9000 platforms. So you have a medium and high volume option as well. And then finally, given the consistent clinical utility outcomes, both in terms of prescribing behavior and referral practices, I could logically see how this could benefit rural and under-resourced communities by supporting better risk stratification among acute infection patients. And so what we found over the last year, as we've seen the successful adoption of MeMed BV globally, is that implementation of this test is definitely a team sport. And so I would encourage anybody considering implementing a test like this to reach out to their clinical partners. Here are some examples of folks that have been involved in these successful implementations that we've been supporting across the world. And do reach out. Many vendors have a tiny but mighty team of folks like myself who have clinical and academic credentials to help you articulate the clinical value of this test to a variety of audiences. So I thank you all for your time and attention.